So my name is Randy, and I'm going to hopefully take you through kind of a different perspective of how we're looking at neurofilaments and our approach to this. So to start with, I'm not a researcher, and I never was a researcher when I started this. I'm a clinical neuroimmunologist, and I treat multiple sclerosis patients. I've done that for 15 years. And we currently have a cohort of about 2,500 patients in our clinic, and we use every therapeutic available in multiple sclerosis, from B-cell depletion to alemtuzumab and so on and so forth. So I want to start by thanking Jens, David, and Henri, because you guys kind of drove this for us many years ago, really in the last year. You drove this technology and this understanding of neurofilaments, and as a group, because we are seeing patients every day and taking care of those patients, our goal has always been to innovate the way we are able to determine what is the right drug for this patient. So I will present our data of real-world neurofilament testing in a population of, at this point, 700 or so MS patients in the real world, ranging in age from 18 to 70, but that's not really the focus I want to be today, because there's still a lot of questions we have about our data. But I want to challenge the room to what I believe is the key for all biomarking, at least neurofilament biomarking, and that's that I think multiple sclerosis is the disease state that is going to answer the question for us first, and I'll explain why that is. So when we think about this beautiful heteropolymer of proteins that kind of sits underneath the axon and provides this cytoskeletal scaffold, you start to think about, from a disease state, what does it actually mean? And how do we apply that understanding to the patient in front of us? So how do we take it from the bench and take it to the bedside? That's really the goal of precision medicine. So we've heard and we're seeing great information on this biomarker and what it means, but how do you take that and extrapolate it into an actual patient? So multiple sclerosis specifically, I believe, helps answer that question to us, and the reason is twofold. We've talked about dementia today, we've talked about Parkinson's disease today, and a variety of other degenerative diseases. Multiple sclerosis is unique in that it is a disease of acuity, in the sense of inflammatory disease, early in the disease, and a disease of neurodegeneration that begins at the onset and continues all the way through, but accelerates later in the disease state. So it gives us a very unique perspective at the way that this protein behaves in real patients. So our efforts, when we first started evaluating neurofilament, at least following the literature, was that this might be a very important piece to a larger puzzle that we have been using for many years to determine what is the best drug. So when you think about MS patients, early in the disease, you see a variety of inflammatory changes, which you can see up here with enhancing lesions. So early in MS, and really any patient who has an active disease, will end up with areas of blood-brain barrier break and will develop enhancing lesions either in the pericallosal territory, periventricular territory, and so on and so forth. Well, also, you see that from early in the disease to later in the disease, the brain goes through this kind of slow atrophy, this slow degeneration. And Dr. Leppert earlier today discussed the fact that that slow degeneration, that atrophy, might be driving the disability that we're trying to stop, right? So how does neurofilament play in to this entire story? Okay? When we get an isolated neurofilament level, can that level tell us anything? And does it tell us something different in a younger patient who's in primarily the inflammatory component of the disease versus a patient who's much older in the progressive component of the disease? Does it stop being useful at a certain point? These are the questions that we're asking in our clinic when we're seeing patients. Is there a point where maybe at a certain age, this might not mean as much to me? And I think those are some of the larger overarching questions that we're finding ourselves asking ourselves when we're getting numbers on patients and as we go forward. So one of the interesting prospects that we believe with neurofilament in the setting of multiple sclerosis specifically is this model that we've used to teach patients. And because patients have asked us, what are you testing? What are you doing? So we tried to think of really a model that would help describe to patients, what is it that we're actually trying to find out. And when you think about two MS patients, and I'll give you some scenarios for those of you who are not clinicians in the room. The neurologists who treat patients will know what I'm talking about. But a patient can come in with multiple sclerosis at the age of 25. They develop optic neuritis, vision loss in one eye. They get complete recovery of that eye. Maybe somewhere along the line, they get a little numbness of an arm. And 40 years later, that patient may be doing perfectly well with very subtle cognitive change and a little fatigue. And they've lived their whole life on a very mild treatment that has little side effects, and they really weren't taken down by their multiple sclerosis. They did fantastic, right? We've all seen, well, if you're a clinician, you've seen those cases. And in those cases, you say, oh, that wasn't a bad disease for that patient. That same patient can present in a different way, where they develop optic neuritis in an eye, they lose vision, it does not come back fully. They then develop weakness of half their body and can't walk. They then develop bladder and bowel issues and no longer can urinate, and they have infections, and they end up in a wheelchair or bedbound. So you have these two patients sitting on your doorstep at the age of 20. And as a clinician, you have to make a decision. And that decision is, what treatment do I put them on? And now we have 16 treatments. Now, if they were all the same, it would be an easy decision, right? However, the treatments vary dramatically. Some of them are like a little knife that you poke the disease with. Some of them are like a nuclear weapon that you annihilate the disease with. And the nuclear weapon works really well for the disease, but it also can destroy the village, and it can kill women and children. The knife is very targeted individually at the disease, but the disease might go rampant and cause all this malfunction. So how do we choose this in the clinic? This is where precision medicine needs to go. So for us, as really an early clinical group looking at neurofilament, that was the question that this is the question we're trying to answer, is how can we take this piece of technology, apply it to that 20-year-old scenario, and apply it to a variety of other markers, not just protein markers, just real-world markers that we use to make the best decision at the earliest time possible to prevent the right patient from progressing over time. At the same time, not putting that mild patient at risk of a very powerful drug that has a variety of toxicities and a variety of long-term effects. So when we're talking about precision medicine, and when we're starting to understand these proteins, what I would love to kind of challenge the room, especially the PhD people who are smarter than me in the room, because I love reading your stuff, is once we determine really a sense of what the protein is doing, I would challenge you to find a clinician who treats that disease state and collaborate with that clinician in real time. Because nothing is more exciting, for me at least now, where I know the patient, I've known them for years, or they're my patient, and I have their neurofilament data with me, and I have their MRI with me, and I have their testing with me, and their cognitive testing. I have that entire picture in front of me and can determine kind of how I'm going to progress. So one of the interesting prospects that I believe is important in MS is you can use this model as a way to understand it. So when we do an MRI on a patient with a relapse in multiple sclerosis, we will see enhancing lesions, right? I showed you that on the earlier slide. That, those of you who haven't read MRI, it's the little white blob, okay? It's basically immune cells infiltrating through the blood-brain barrier. However, the first patient I described to you, that patient who developed optic neuritis and had complete recovery of that eye, okay? That patient's MRI will show an enhancing lesion on the optic nerve. However, clinically, they have no foundational or very little foundational damage. So their neurofilament level, presumably, would go up a little, but then return to their baseline relatively quickly, we think, and really not go up extraordinarily high, okay? And this is our model of how we're starting to see this in our clinic and what we believe. The second patient who developed optic neuritis with incomplete recovery, so their disease is more aggressive, their disease is causing more foundational loss. That patient would be represented by the third picture there, the earthquake. And that's where you're seeing enhancing lesion on the MRI, just like the first patient, but the difference is microscopically, you have much more foundational loss, much more damage occurring, and that's a patient where neurofilament, I believe, will help us decide on a potentially more aggressive treatment. So again, these two patients come in with the same thing, but don't end up the same. Their MRIs will look the same. So the challenge is, can we take the biomarker and make it kind of a driver for how we're going to drive this car for that patient as early as possible? And the third scenario, the flooding scenario, really represents neurodegeneration, okay? And this is the degree to which the concrete under the home is eroding, okay? Now, these are not mutually exclusive. So patients can have a variety of this, okay? Every MS patient can. But can we use the neurofilament level? Can we use biosignatures, whether it's GFAP or synaptic proteins, or who knows what it's going to be as we continue to go forward? Can we use it to determine what type of home this patient has and apply the correct treatment to that patient in that setting? And that is the most exciting part about neurofilament testing to us in the real world and for our patients, because there's nothing more exciting than objectively seeing that a drug may be working. And we have seen that to date in our clinic. So one of the questions I had when we first started this was, and I was terrified of, was if we do this in real people, people who have diabetes, people who are hypertensive, they smoke, they're on every drug in the world. I mean, and these are Americans, so most of them are fat, and it's, we wanted to know, I can say that because I'm American, so I'm allowed to say it. You guys can't make fun of us, we can make fun of ourselves. So one of the questions was would this information, would it hold water against the retrospective data that we had in a healthier population, really 40-year-olds with MS who were in phase 3 trials? And the age effects obviously held extremely strong, and really and these are treated and untreated. These are a variety of MS patients. But as you can see, up to the age of 50, you really have relatively low neurofilament levels. Above the age of 50, it gets a little trickier. And so I will caution, at least from our standpoint, that above the age of 50, I don't know that neurofilament alone is going to be applicable clinically. I think as part of a larger signature of proteins, it will be. But I think really neurofilament, once you get into that older population, I think it's going to be much more challenging. What about predictive of functional outcome? Now, this really surprised us when we saw this in our data. So the 9-hole peg test is a simple test of dexterity. How well does someone's hand work, right? So in MS, in our clinic, we do this every single time we see a patient, and we track their time. We measure how long it takes them to put nine holes in and take 9 holes out. And it's a verified test that's used across the board in multiple sclerosis, okay? And amazingly, when we corrected for age, a single neurofilament level was predictive of 9-hole peg time. So I could take a patient's neurofilament level just one time, right? Regardless if they're having a relapse or not, this is kind of on the broader scale. And it essentially could tell me how much functional disability they have in an arm, which I thought was pretty profound. And then we said, well, could it do that with ambulation? So we do the 25-foot timed walk. And the 25-foot time walk, again, a validated test in multiple sclerosis. We basically walk patients for 25 feet 2 times every time they come in. So for example, I've been seeing you since 2004. I have hundreds of walks on you, and I've been tracking your speed over that time period, right? And variations of 20% or so tell me that there may be some disease progression. I mean, this is where we were biomarking. I mean, our biomarker, and this is considered elegant. Most people don't even do it. So our biomarking is really 25-foot time walk, 9-hole peg, MRI, essentially, right? And then clinical exam. So, but we use that. We use it quite a bit. And again, just like the 9-hole peg, when you correct for age, a single neurofilament level was predictive of where they were on the scale of 25-foot time walk. So we were able to, in the first batch of isolated tests in real patients, see that it matters in terms of functional outcome. It really does. And so the inverse of that is now, if we are able to decrease these neurofilament levels, can we see improvement? Can we see changes on these functional outcomes that are meaningful to patients? And then the next question that we had that was a concern to me was, we saw Dr. Leppert's slide earlier about Gilenya versus interferon, and he showed that Gilenya had a much more dramatic neurofilament drop than interferon. Well, one of my concerns was, what if all these treatments really aren't that different? I know we know they are clinically, we see changes, but what if on a neurofilament level we're not seeing differences? Because otherwise this is very challenging. What's the point of having precision medicine if all the medicine really is not targeting how precise it is? And I can't release this information. So, and again, a lot of our data is still embargoed because it's in publication right now, so I'm releasing what I can. So I took the names of the drugs off. But very interestingly, we saw a very broad range of treatment effect. So medication A through H there represent different MS treatments. And the bottom one is people who are not on treatment yet. So these are either new patients or patients who have never been treated yet who are just getting on to treatment. This, to me, is a very important slide because it indicates that what we do matters and how we track it matters. Now, I know I'm not teaching you anything new about neurofilament yet, and I understand that, but we've been doing this for 6 months now in the real world, and this is our real first batch of data. We are now into our second and third draws, and many of those patients have had treatments that have been changed during that period of time. And we believe that's going to be one of the most important things to see is what happens if we're able to drop their levels. What do we see? And then the next step for us is how do we apply this level to really help us on an individual basis? In the end, we've heard echoes today of biosignatures, and I think I agree with that 100%. But I don't want us to get into the mindset of biosignatures only being proteins. In the setting of Quanterix it is, I understand that, for the most part, but a biosignature to me, and what we're trying to do is develop a next generation data set that aims at decision thresholds. So using neurofilament, using a variety of other proteins, using 9-hole peg, 25-foot time walk, spinal cord atrophy, thalamic atrophy on MRI. When we develop ratios and fingerprints, can we apply decision thresholds very early? In the end, what I'd say is this. After 6 months, we are more excited now than we were when we started. And so this is, to me, this is real deal. And we're very optimistic about where this is going to go. I was worried that I wouldn't be anymore after it started, but this is pretty cool stuff. So thank you for your time. If you have any questions, we're here. So thanks.